right. Hi, you guys. Welcome back to the I Believe podcast. Today we have the pleasure of speaking with Dr. Katherina Alsina, and she goes by Kat, who is the Associate Director of the Uveal Melanoma Division at Castle Biosciences. So Castle is a commercial stage diagnostics company that is focused on providing physicians and their patients with personalized, clinically actionable information to make more accurate treatment decisions. In layman's terms, they're the ones who do our biopsies for the ocular melanoma community. So we're really glad to have Katherina or Kat with us here today and to have her tell a little bit about herself and about Castle. And we're just going to be going through and answering a few questions that, maybe you didn't really know about Castle and about the tests that they offer for uveal melanoma patients. Okay, so Kat, can you just tell us a little bit about yourself, like your background personally and your role at Castle Biosciences?
Yes, sure. I'm originally from Houston, Texas. I am a scientist by training. I did my graduate work in molecular biology here in Houston, and then came to Castle in 2019, where I'm now supporting our uveal melanoma division, as you said. I'm the head of medical and scientific affairs for our uveal melanoma division. So in this role, I spend kind of half of my time providing support for the physicians who utilize our tests, and the other half driving our uveal melanoma research initiatives. And we really have an incredible team of scientists at Castle that support our research and development work. I don't think many people know that all of Castle's tests are rigorously validated through peer-reviewed studies. And that's really important because we want to ensure that patients are provided with the most accurate and actionable information possible.
That's amazing. Okay, so can you tell us a little bit about how Castle Biosciences actually got its start, just as a company in general?
Sure. Our CEO, Derek Matzold, founded the company back in 2008 with Kristen Olschlager, who is currently our Chief Operating Officer, and Toby Juvenal, who's our Chief Commercial Officer. And their initial goal was to improve care for patients affected with rare cancers. So our first test was actually the DecisionDX UM test for patients with uveal melanoma. So this is the test that tells the patient the class of their tumor. And the test was originally developed by Dr. William Harbour, who's a prominent clinician scientist, and then Castle in-licensed and launched that test clinically in 2009. So our uveal melanoma test is really how we got started in the molecular diagnostic space. And since then, the company has really grown and evolved, and our scope has expanded to include tests for skin cancers like skin melanoma and squamous cell carcinoma, for Barrett's esophagus, and most recently for mental health disorders.
That's awesome. So basically, uveal melanoma and the testing for that was like your baby, so to speak, as a company. It was the first thing that you guys really worked on. And I guess, in my opinion, if it's the first thing you work on, it's the thing you get really good at. So today's focus, our discussion, is mostly just on the molecular prognostic testing in ocular melanoma. Can you tell us a little bit more about what molecular testing is and why it's important for the newly diagnosed patients with OM to discuss this option with their doctor?
Yes, molecular testing is really leading the way for precision medicine, and most physicians who treat uveal melanomas are very in tune with these advances. They're discussing the option of molecular testing with their patients. Our testing, Castle's testing, requires a tumor biopsy, and it allows us to analyze a number of different biomarkers in the tumor to kind of determine its molecular signature, if you will. So this type of individualized tumor profiling is really important because it allows the physician to tailor their treatment and surveillance approach based on each patient's unique biology. And in the case of our uveal melanoma test, it's really important for patients to know that the tissue has to be collected, that the biopsy tissue has to be collected before the tumor is exposed to any treatment like plaque brachytherapy or proton beam radiation. So the timing is very important because we need a sample of the tumor kind of in its original state in order to get the most accurate indication of how aggressive it might be.
Okay, that makes sense. So you mentioned molecular testing. Just to clarify for our listeners, is molecular testing the same as genetic testing, or are they different?
Yeah, that's a really good question. These terms, molecular testing, genetic testing, genomic testing, they're many times used interchangeably to describe the type of testing that we perform, but there are actually differences that are important. And without going into too much detail, I'll just say that kind of across the board, the type of testing that Castle provides is molecular tumor testing. So that's kind of the best terminology to use to avoid confusion. However, our uveal melanoma tests specifically are genomic tests. We don't really refer to them as genetic tests. That isn't, it's not incorrect, but the term genetic testing is commonly used when referring to inherited diseases that are passed down through families. So we try to kind of avoid using that terminology when talking about cancer testing, unless of course there's an inherited component.
Okay. So can you tell us a little bit more specifically about each of the Castle uveal melanoma tests? What exactly do they measure? What kind of information do they give us as patients? And obviously as the clinical community, what do they give the clinical community?
Yes, we offer 3 different molecular tests for newly diagnosed uveal melanoma patients. And together, these 3 tests can provide a very comprehensive molecular profile of the tumor. And all 3 of them can be run from a single tumor biopsy sample. So it's now possible to get a lot of information from a very small amount of tissue, which is incredible. In the US, these biopsies are typically performed using a very small gauge needle to aspirate or suck up just a tiny bit of the tumor for testing. And our platform can run all 3 of these tests with this small sample. Our main uveal melanoma test is DecisionDX UM, so that's the test that gives the tumor class. It has been studied and validated over the years and is really the only test of its kind to have undergone such rigorous validation. So that test is a prognostic test. It's not a diagnostic test. And it measures the activity of 15 specific genes within the patient's tumor to determine the likelihood of the tumor spreading or metastasizing from the eye to other organs. And so the test can identify the tumor as being either class 1A, class 1B, or class 2, with the class 2 tumors having the highest risk for spreading.
Okay. So when they have those results of the prognostic testing from the DecisionX or the DecisionDX UM test, how are those results then used by the patients, by the doctors who get those results, and I guess as well in research?
Yeah, well, knowing the molecular class of the tumor can be extremely helpful to patients and their doctors in planning their follow-up care. There are considerations about the kind of monitoring and the frequency of monitoring that the patient will need to detect metastatic disease, and whether the patient would be a candidate for certain treatments or clinical trials as they become available. So, while the DecisionDX UM test can't guide your doctor toward a specific therapy, there are studies which have shown that the class result has a significant impact on the management of uveal melanoma patients. So, most ophthalmologists in the US who treat uveal melanomas are using molecular testing, and national guidelines recommend increasing the frequency of metastatic surveillance imaging for those patients who have high-risk test results, so class 2 test results. But of course, the decisions around surveillance, treatment, and other follow-up plans should always be made between the doctor and the patient.
Okay, so you mentioned that Castle offers 3 different tests for ocular melanoma. What are the other 2 besides the DecisionDX UM? And just go ahead and tell us what are those other 2.
Yes, so we offer 2 additional tests that can all be performed, again, from the same original biopsy sample that we use to run the DecisionDX UM test. We can perform PRAME testing using our test called DecisionDX PRAME, and we can perform DNA sequencing to identify mutations in the tumor DNA using a test called DecisionDX UM-Seq. So it's important to remember that the test that gives the class result, the DecisionDX UM test, is the only one of the 3 that has been prospectively validated and confirmed across multiple studies. So these other 2 tests are optional add-on tests because their prognostic value is still under investigation. but they can provide kind of a more complete picture of the tumor to potentially help refine a patient's individual risk for developing metastatic disease.
Okay, that makes sense. So can you talk a little bit more about PRAME and the DNA mutations, why this information is important to have in addition to the class result? Because obviously you mentioned it can be helpful, but what's the reason behind that?
Yeah, PRAME stands for preferentially expressed antigen in melanoma, and it's a gene that's usually not found in normal adult tissues, but in some cancers like uveal melanoma, PRAME levels are abnormally elevated. And so there's a lot of interest around PRAME because recent studies in uveal melanoma have found that increased levels of PRAME in the tumor is associated with riskier tumors that are more likely to spread. And so specifically, if we get into kind of the nitty-gritty of these studies, they have shown that a class 1 tumor that is PRAME positive, so that has elevated levels of PRAME, may be associated with an increased risk of metastasis compared to a class 1 tumor that does not express PRAME, so PRAME negative. And then in the case of class 2 tumors, which already have a higher risk of metastasis, PRAME positivity may be associated with a shorter time to metastasis than the PRAME negative class 2 tumors. So again, it's important to emphasize that the studies about PRAME were retrospective studies, so they were not kind of the gold standard for validating biomarkers, but there is an ongoing prospective multicenter study called the COOG-2 study that aims to prospectively validate PRAME. So until we have the results of that study, we can't really say for sure exactly what the impact of PRAME status is on a patient's risk for metastasis. And then as for our sequencing test, we have this DNA sequencing test called DecisionDX UM that can identify mutations in 7 important genes in a patient's tumor. And so like the PRAME test, this DNA sequencing test is an optional additional test. It can be run from the same biopsy sample as the other tests. And there are multiple potential applications of this test, but researchers believe that identifying mutations in these 7 genes may aid in kind of refining a patient's prognosis and may someday help guide treatment decisions. But like PRAME, these mutations really require further validation before we understand their exact role in prognosis.
Okay, that makes sense. So what about patients who have their tumor class from a biopsy result, but they don't have PRAME status or mutation status on that result?
Yes, we would like to inform patients that if they were tested in 2016 or later, our clinical lab may have residual tissue stored that we could go back to for PRAME testing or for the DNA mutation testing. And patients can check on this at any time by calling our clinical services team, and maybe we can provide that information afterwards.
Okay, and this is, I guess, kind of a follow-up question to that one, but if they can find out if they can have that tissue retested after 2016, do you know when those tests, like all 3 of them, became available, like date-wise?
Yes, so PRAME became available in 2016. Our sequencing panel is newer. It became available around early 2019, and it really hasn't become widely utilized until just this past year.
Okay, I feel like that's good to know. Okay, so will the molecular testing results help patients qualify for clinical trials?
Yeah, it is becoming increasingly common for genetic information to be included as part of the requirements to qualify for clinical trials for specific therapies. And I'm sure, as you know, searching for clinical trials can be really confusing. And so Castle's UM team has put together a list of the currently recruiting trials for uveal melanoma patients. We have one list for those patients who have been diagnosed with metastatic disease and another for those who have not been diagnosed with metastatic disease. And so these clinical trial lists are updated quarterly and distributed to the physicians that we have in Castle's database. But we also post them to our website under the resources tab, so they're available to everyone.
Okay, that's good to know. We'll need to get that, I guess just follow up and put that link to the resources tab in the show notes so that people can go and check that out. Okay, so what happens to any of my biopsy material, say like like mine personally was done in 2020, if there's any that's unused, can it be saved to use as testing advances? Like, because it was such a small sample.
Yeah, great question. So typically, if all 3 of our tests are requested by the physician, so the DecisionDX UM, PRAME, and sequencing, if all 3 of those tests are run, then typically the biopsy sample will be totally exhausted, so there will be none left over. But we do offer an option for patients to have an additional biopsy sample stored in our tissue repository program, free of charge for a period of up to 5 years. And so to benefit from this program, patients just have to discuss the option with their doctor to understand, any potential risks associated with having that extra aspirate taken. And the patient would need to sign a consent form to allow us to store their tissue.
Okay, I feel like that's helpful to know. So what if a patient, in that case, they're offered the storing of the tissue and they do not? Let's see, what if the patient does not use the additional stored sample? Then what happens if the 5 years has passed?
Yeah, based on the terms of the consent form as it currently stands, we are required to destroy the tissue after a 5-year period if the patient hasn't requested that we send it elsewhere or use it for further testing. However, this tumor tissue is a precious resource, and so we are considering modifying this program potentially in the future to facilitate research studies, for example. So patients might have the chance to opt in to having their tissue transferred to a research biobank after a certain number of years, for instance.
Okay, that's going to be an interesting development for sure. So what about the patients who maybe they did not have the option just because of when they were diagnosed to have a tumor biopsy sent for molecular testing?
Yeah, in the absence of molecular testing, usually the physician will be able to estimate a patient's prognosis based on, a very comprehensive clinical evaluation where they're looking closely at the different clinical pathologic features of the tumor, so like the tumor diameter, the tumor thickness, and other staging factors.
Okay. So let's move on a little bit to some of the kind of the big questions that I think people get in the uveal melanoma community around the Castle biopsy is, how are the tests billed? Does Castle offer any financial assistance program to the uveal melanoma, ocular melanoma patients?
Yes, we work with all insurance providers, Medicare, Medicaid, commercial insurers, the VA, to secure coverage for our testing services. We have a phenomenal billing team that will submit insurance claims and manage the entire insurance billing process on behalf of the patient. And in the event that a claim is denied, our billing team will go through an appeals process to fight for coverage. So the patient will not have to worry about any of that. But it's really important for patients who are getting the test to know that they will receive a welcome letter from Castle explaining the process. And I encourage patients and their families to read through that letter because it will provide a lot of clarity, hopefully some relief, and contact information in case they have any questions. And regarding, financial assistance, our founders have always believed that quality care should not depend on a patient's financial situation. And so we also sponsor an industry-leading financial assistance program that can provide help for uninsured patients and patients who might have insurance plans with really high deductibles or copays. So many patients have benefited from that program, and it really keeps the test from being cost prohibitive.
Okay, I feel like that's really good to know, and also good to just be reminded that there is, information mailed out to each patient for them to read. And I guess maybe just to make a note that if you as the patient are overwhelmed by that letter, because sometimes we are, to have your family or your friends or somebody else read it for you and just kind of save it for you so you can go and read it again later. When you're maybe more mentally and emotionally prepared after all of the crazy happens with the diagnosis. I know I probably got the letter, but I'm pretty sure I didn't look at it personally because everything was just so crazy. But it's there. It's good to know that it's there and it's being told. Okay.
And the contact information to our billing team, patients, can feel free to call our support team at any time to ask questions if reading through that letter is
really
overwhelming.
And I know